Hello and welcome to Clinical Society meeting. Today in the Clinical Society meeting, the first presentation is from Department of Neurosurgery, and I request Head of the Department, Dr. Ravi Shankar, to initiate it. Over to Dr. Ravi Shankar.
Thank you, Dr. Abhishek. Good morning, everyone. Good morning, Director sir. Today, on behalf of Department of Neurosurgery, Dr. Rajiv Raman will be presenting an interesting case of rare skull tumor. So, over to Dr. Rajiv.
Good morning, everyone. I am Dr. Rajiv Prasad, Neurosurgery, presenting a rare skull tumor. Patient Mr. Devashish, 15-year male student from Varanasi, UP, has came to us with presenting complaints of large swelling behind right ear since 9 months. Patient was symptom-free 9 months back. Then he noticed small swelling behind right ear while combing his hair. It gradually increased in size over 2 to 3 months. It was not associated with pain, fever, ulceration, or similar swelling over the other side of body. For which he was operated at private hospital Varanasi 6 months back, and tissue was sent for histopathological examination and diagnosed as a case of chondrosarcoma grade 2. 1 month after discharge from hospital, he noted a discharge to the drain site of his scalp, and also noticed increase in size of swelling in 1 month, which rapidly progressed to 15 to 20 times the previous swelling in 3 to 4 months. And patient presented to us with large, painless, progressive, recurrent fungating mass behind the right ear. Negative history. Patient was having no history of unconsciousness, seizure episode, headache, and vomiting. No history of ear discharge and hearing loss. No history of paresthesia or pain over face, facial weakness, or facial asymmetry. No history of loss of taste sensation. No history of bleeding. Past history, no similar type of illness in past. No family history was not relevant. Personal history was not contributory and belongs to middle socioeconomic status. Treatment history: patient underwent excision at private hospital Varanasi in July 2021 and histopathological examination at that time suggestive of chondrosarcoma grade 2. Patient also taken single fraction 6-way radiotherapy received outside to our hospital 7 days before admission to our hospital. Now come to the loco-regional examination. About 10 to 12 centimeters C-shaped scar present behind the swelling. This is the picture of the patient taken up with permission of the patient. And facial symmetry was maintained. Swelling was approximately 16 into 14 centimeters size, which was irregular, oscillated, grayish-black in color. And present over right retroauricular area involving parieto-occipital region with forward pushing of right ear. It was covered with slough and area of blackish discoloration. Foul smell was present. Swelling was non-tender, firm in consistency, fixed with underlying bone. No regional lymphadenopathy was present. Swelling was non-pulsatile, and impulse on cuff was not present. On general examination, patient is conscious, well cooperative, well-oriented with time, place, and person. Vitals were stable. VCS was full. On systemic neurological examination, all cranial nerves were intact. Motor examination, bulk bone power were normal. Sensory examination was normal. Deep tendon reflection normal. Plantar bilaterally downwards. Other systemic examination like chest, CVS, and abdomen were normal clinically. This is the picture of the patient taken from the front, showing large fungating mass present behind the right ear with area of blackish discoloration slough. This is a picture taken from the behind, showing large scar of previous surgery operated outside. This is a CT scan of the patient at the time of presentation to our hospital. CT scan showing heterodense lesion of over right posterior parieto-occipital region with intracranial and extracranial calvarial extension. Lesion is osteolytic, destroying both outer and inner table of bone, with spickled area of calcification in extracalvarial portion. Intracranial portion is hyperdense and causing local mass effect without any gross midline shift. Rest of brain parenchyma is normal. Normal mastoid ear cells maintained. Lesion is separate from external ear and middle ear cavity. This is picture showing extracalvarial spickled calcification in extracalvarial portion. This is showing external and middle ear, normal external and middle ear, and showing hyperdensity in intracranial portion with local mass effect. No midline shift is seen. This is 3D CT scan of the patient showing the extension of the lesion. It is involving right parieto-occipital bone with extracranial calvarial extension anteriorly to reach the posterior part of the temporal bone, posteriorly to reach the inferior part of the lambdoid structure, inferiorly to reach the upper part of the mastoid process. This is 3D CT showing oscillated appearance with extension as described earlier. This is CT angiograph of the patient showing no significant major feeder vessel supplying the tumor. Now come to the progression of disease. This is a picture of the patient when patient noticed initially small swelling behind right ear while combing his hair. This is a CT scan at the time of the initial presentations showing a small osteolytic region over the right parieto-occipital region with expansion of both inner and outer table, with small osteolytic lesion with expansion of both outer and inner table. Patient was operated in July at private hospital. After 1 month from the discharge, after discharge, patient noticed again recurrence of swelling only in 1 month with discharge to the drain side. This is a picture of that patient. CT scan at that time also showed there is recurrence of swelling at the same site of the previous operation in August 2021. This is a picture of the patient taken after 2 months in September 2021, in 2 months after surgery, showing there is an increase in the swelling side and there is a cauliflower-like starting of the cauliflower-like growth on the same side. This is CT scan of the patient showing there is a recurrence of at the same site. Picture taken in October 2021 showing the increase in the size of the cauliflower-like swelling fungating mass. CT scan in October 2021 showing recurrent lytic lesion expanding exteriorly more to exteriorly. Now come to the treatment plan. Our treatment plan in such a aggressive tumor is re-excision of tumor and reconstruction followed by radiotherapy. Aim of surgery. Our aim is gross total resection with minimal skin loss, preservation of vital structures and neurological functions, especially cranial nerves, and improve the quality of life of the patient. Steps of the surgery. Patient was written informed consent was taken for the surgery under GA. Patient was positioned in park bench position with right side up. Head and neck was elevated 15 to 20 degrees to improve the venous flow. Incision inverted U-shaped flap based on right occipital artery is raised centered on base of fungating mass. And then debulking of fungating mass was done, followed by gross total resection of intracranial tumor. And finally, hemostasis was secured. Intraoperative findings, tumor was firm to hard in consistency, highly vascular, involving right parieto-occipital region of the skull bone, extending anteriorly to reach the posterior part of temporal bone, posteriorly extending up to the lower part of lambdoid suture, inferiorly up to the base of mastoid process. Tumor was awaiting dura, but not infiltrating the dura. This is the intraop picture. This is intraop picture after the debulking of the external fungating mass. This is intraop picture after removal of whole of the fungating mass and the intracranial calvarial portions. So showing defect of about 5 into 6 centimeters with clear shining intact dura and removal of all macroscopic involved segment of the tumor. Now there is a problem with us to close the wound. So the help of the plastic surgery department is taken for reconstruction of the wound. Now I request Dr. Alna, plastic surgery SR, to explain about the reconstructive procedures, and Dr. Vikas, assistant professor of pathology, to explain about the histopathological examination report. Dr. Alna, please.
Good morning to all the faculty members and my colleagues. So after this defect was created, we went forward with the reconstruction. So the reconstructive options which we had for this defect in the right parieto-occipital region. So first of all, we had local flaps in which we could do a transposition flap. Second, it was followed by loco-regional flaps in which we could do a trapezius myocutaneous flap or an extracorporeal radial forearm flap. And third is the free flap in which we could have done a radial forearm free flap, anterolateral thigh flap, and latissimus dorsi flap. For elective reconstruction, tissue expansion is the best option to transfer the hair-bearing skin into the defects. Now, in this patient, A transposition flap based on the superficial temporal artery was used, which resurfaced the defect, and the donor area of the flap was then skin grafted. Calvarial reconstruction was deferred in this case, which could be done with alloplastic materials like a titanium mesh plate or polymethyl methacrylate implants. And other options for calvarial reconstruction include calvarial bone graft and split rib graft. So here is the immediate post-op picture. After the transposition, the defect was covered and the donor area was skin grafted. Thank you.
Now, this is the histopathological examination of the patient operated outside, showing the suggestive of chondrosarcoma grade 2. Now I request Dr. Vikas, Assistant Professor Pathology, to explain about histopathological examination.
So, good morning, everyone. So, we received the sample in 3 containers in multiple parts, and the larger tissue piece was 11 centimeter in diameter. The cut section of the tumor was solid gray with area of punctate calcification, and there was a large area of necrosis hemorrhage, and also gelatinous area was present. So this is the scanner view of the histopathological slide of the tumor. You can see there is a cartilaginous tumor, and which is present in the lobule, and it is very cellular, and there is also the presence of large area of the necrosis. So this is the low part view of the tumor. You can see there is a presence of the lobule of cartilage, which is highly cellular, along with there is a very cellular area in between this cartilage. This is the high power view of the tumor. You can see there is a marked nuclear irregularity. Nucleus are enlarged with prominent nucleoli, and there is a scanned cytoplasm, and many of the cells show very bizarre nuclei. And pleomorphism is very high grade mark, and you can also see this beautiful mitotic figure. And this is another high power view of the tumor. You can see there is a trinucleate chondrocyte, and there is also binucleation, and there is a cartilage differentiation, and there is a marked nuclear pleomorphism, and there is also atypical mitosis. So grading of the chondrosarcoma is based on the nuclear features, presence or absence of necrosis, and the mitosis. So grade 1 tumors usually have moderate cellularity. They usually look like the enchondroma, but the differences is based on the histological or the radiological feature of the infiltration. Grade 2 tumors have the high cellularity with moderate nuclear pleomorphism and nuclear hyperchromacy and nuclear enlargement, but they do not have the significant mitotic figures. In grade 3 tumor, there is a significant mitosis and there is a marked nuclear pleomorphism, hyperchromacy, and other high-grade nuclear feature like the bizarre nuclei. So based on this nuclear atypical nuclear feature and the presence of significant mitosis, in this case there was 22 mitosis per 10 hyperfluid, which reported it as a grade 3 chondrosarcoma. So previously, in first time it was reported as a grade 2 chondrosarcoma. This time it was reported as grade 3 chondrosarcoma. So in 10% cases in the recurrence, we can see the higher grade of tumor in chondrosarcoma. Thank you.
Thank you, Dr. Vikas, sir. Now, this is the picture of the patient few days after the surgery. Post-op picture showing small necrosed area along the site of primary skin closure. This is a picture of the patient at the time of discharge, showing healing of all of the wound along with the necrosed area. This is a CT scan of the patient at the time of discharge, showing gross total removal of tumor with no macroscopic residue or recurrence till date. Now come to the follow-up plan. Our follow-up plan is repeat CT scan after 1 month, along with routine blood investigations, X-ray chest, and ultrasound abdomen. Present condition of patient is taking radiotherapy at Mahamna Hospital. Now come to the detail about the chondrosarcomas. Chondrosarcomas are rare malignant mesenchymal tumor of cells derived from the transformed chondrocytes, approximately 20% of all cases of skeletal system cancer. Usually occur in pelvic bone, shoulders, and along the superior metaphyseal and diaphyseal region. Intracranial chondrosarcomas are rare lesions that are diagnosed in 1 in 1,000 cases of intracranial tumor. Only 2% of all chondrosarcomas are found at the skull base, thus accounting for a 0.1 to 0.2% of prevalence. Pathogenesis of chondrosarcoma remains unclear. It developed from the chondrocyte within a rest of inchondral cartilage present within the skull base. Common locations of chondrosarcoma according to decreasing order of frequency are petrous temporal bone, clivus, temporo-occipital bone, sphenoid bone, parietal occipital and orbital bones are rare sites. Now come to the clinical feature. Usually present with mass effect on adjacent brain stem or cranial nerves. And second common presentation is compression of structure of the superior part of the neck. Bony and soft tissue outgrowth, as in our case, is a rare presentation. Now come to the histological subtypes. Conventional subtypes having hyaline and myxoid cells are most common in 80% of cases. Mesenchymal type 17% cases. Clear cell and dedifferentiated types are rare in skull. Grading of chondrosarcoma are well differentiated, moderately differentiated, and poorly differentiated, as described by the Dr. Vikas. Now come to the prognostic factor. Histological subtypes, previous treatment, either surgery or radiation therapy, extent of tumor resection, and use of adjuvant postoperative radiation. But local recurrence is considered to be the most significant predictor of overall mortality. This is a 5-year literature showing 5-year recurrence rate by treatment modality. If surgery alone is done, then recurrence rate is around 43 to 44%. If radiation alone is done, then recurrence is around 15%. If radiation and surgery both are given, then recurrence is around 9%. This is a literature showing 5-year recurrence rate by treatment history. There is no difference between the either previously treated or not treated, either by any mode surgery or radiation. This is 5-year recurrence rate according to histological subtypes. In conventional type, recurrence is around 15 to 16%. In mesenchymal type, recurrence is around 63%. This is 5-year recurrence rate according to histological grade. In grade 1, recurrence is around 15%. In grade 2, recurrence is around 18%. And in grade 3, recurrence is around 33%. This is the literature, few literatures I have collected. One study in 2009 of 560 patients, in which 2 treatment types were selected, surgery and along with radiotherapy. Results were 5-year mortality rate in case of surgery 25% and 9% in the cases of surgery and along with radiotherapy. Second study in 2014 over 226 patients in which surgery and radiotherapy were taken, in which 10-year survival rate of the patient with surgical treatment is 69.3%, for the patient without surgical treatment is 53.9%. Third study in 2015, in which stereotactic radiosurgery was tried, in which 5-year and 10-year survival rate without progression is 85% and 70%. Another study in 2016 over the 159 patients in which surgery along with proton beam therapy was given, suggesting overall 5-year, 10-year survival rate is around 94.9% and 87%, suggesting that proton beam therapy had good result. Another study in 2015 over 45 patients in which surgery along with radiotherapy were given. Results were 5 and 10-year survival rate without progression is 70% and 56%. Another study in 2015 over 77 patients in which only proton beam therapy were given. Results were overall 8-year survival rate is around 93.5%. Another study in 2018 over 47 patients in which surgery along with radiotherapy were given, in which 5-year and 10-year survival rate without progression in the case of surgery is 68% and 52%, and when surgery and proton beam therapy both were given, results were 5-year and 10-year survival rate were 100% and 88%. Last study of 2020 over 158 patients with surgery and radiotherapy showing overall 5-year and 10-year survival rate is 95% and 70%. This suggests that proton beam therapy along with surgery has good result. Now come to the conclusion. Current optimal strategy comprises maximal safe resection followed by radiotherapy. When scheduling a combined therapy, priority should be given to the quality of life of patient along with preservation of neurological functions, especially cranial nerves. Radiotherapy always has survival advantage, but proton beam therapy has very good result. Now, why in CSM? It is a rare case, very rapid progression of disease, as we have seen in pictures. In about 6 months, patient developed large fungating mass, as in our case. It is very difficult to operate with radical excision. It always requires multidisciplinary approach, like in our case, Department of Neurosurgery, Plastic Surgery, and Radiotherapy. Now, take-home message. Early detection with maximal possible safe resection followed by radiotherapy is the prime treatment in such aggressive tumor. Recurrence is inevitable in such aggressive tumor. Multidisciplinary approach and frequent follow-up is the key to prolonged life in such patients. Thank you.
Thank you, Rajiv. So I request head of the department, if you want to conclude or if you want to add something in the presentation, you can add, then we will start taking questions from the chat.
Thank you, Dr. Abhishek. So it was a well-diagnosed case of chondrosarcoma, which actually was very fast growing. Normally, chondrosarcomas are tumors of pelvic bones and other bones. Skull chondrosarcomas are very rare tumors. And in fact, if they are present in skull, they are usually located at skull base regions and more towards the lateral skull base, like the petrous, as Dr. Rajiv already told. Tumors of the vault, this was almost like a vault tumor. There was no association of skull base. So vault tumors of this region is usually very rare, actually very rarely reported. So this was a rare diagnosis of the skull and a rare site of the involvement of the skull. Another reason for presentation in this forum is this was a very vascular kind of tumor. So far we were until we excised the whole of the tumor, the bleeding did not stop. In fact, about 1 liter of blood loss was there while resecting the tumor, and that is why the reconstruction was deferred on that day. The patient became hemodynamically stable, and then we planned to reconstruct the defect 2 or 3 days later. It was done. So that is one reason why it is a difficult tumor. And moreover, it is usually attached to the underlying structures. In our case, cranial nerves are not in the vicinity, but the underlying dura and the sigmoid sinus laterally and the transverse sinus inferiorly are very in very close proximity to the tumor, and they are very likely to be affected. So we had to take care of that also. And of course, the reconstruction part, that is very well taken care of by the plastic surgery team. I'm very thankful to Dr. Umesh also. These tumors are very fast growing. Even from the literature, we can see that recurrence is inevitable in these cases. 100% recurrence occurs. Maybe that occurs very soon, or sooner or later recurrence is always there. So we have very less options left with this patient. The gold standard treatment following surgery is the proton beam therapy, but I think proton beam therapy is not there in India everywhere. It's present there only in Chennai Apollo Hospital. So I think the patient, since the patient was already registered at Mahamana Cancer Institute, so we sent there, and the patient has now been started radiotherapy. Let's see. Only 15 to 20 days back he was discharged, and we will follow, and then we'll take care of the recurrence.
Okay. What is the role of immunotherapy in such type of cases?
As per literature, there is no role of immunotherapy.
Because I think if you review the literature, there are some immunotherapy has been tried also.
In skull tumors, in literature, not written, sir.
Okay.
I have seen many literatures. In long bones, it is written, sir. Long bones chondrosarcoma, it is written.
Okay, not in the skull tumors.
Yes.
And how you are going to long-term follow up this patient post-treatment surveillance?
I have searched literature. There is no protocol found by me, but we have planned to follow up monthly to up to the 3 months, and 2 monthly up to the 1 year, and then after 6 monthly.
Okay. So what will be what things you will include in the post surveillance?
Post-surveillance, we will do CT scan of the patient, CT head, along with initially with X-ray chest, ultrasound abdomen. If we suspect recurrence, then maybe by CT scan, CECT thorax, CECT abdomen. Usually, skull chondrosarcoma does not metastasize, but in grade 3, it may go to the other part of the body. Can go up to the lung. So major concern of to look for the metastasis is lung.
Okay. I request Professor Ajay Khanna, sir. Sir, you can unmute yourself and ask your question.
I think I must congratulate the neurosurgery team for doing excellent work of the excision of such a horrendous tumor which was there. First I thought probably it is a big vascular malformation which is there. Sometimes the big vascular malformation they present like that. I just wanted to know that, they have done the good excision, but, the normal practice is to excise the previous scar along with that, which probably has not been done in this patient, because that is the normal, whenever you go for the re-excision, you have to excise the previous scar which is there.
If we excise the scar, so then the defect will be of larger size. Then we will get more difficulty in closing the wound. So we have planned
your aim was here to achieve a good palliation, because once the scar is there and you have left the scar there is bound to be having the recurrence there. It is this tumor already has got a very high propensity for the recurrence, but once you have left that scar which is there, it is likely to be having a very high or very early recurrence. It will be there.
Sir, may I speak, sir?
Yeah, please.
Sir, actually, the patient was operated previously at some other hospital at private center. The scar was actually quite behind the tumor. I don't know how and why it was done. The scar was quite behind the tumor. The tumor was actually quite anterior to the tumor. So I thought the scar was not involved in the tumor. That is why we deferred to excise the scar.
And I was just wondering that why in this patient the radiotherapy or some type of chemotherapy, if it is there for the chondrosarcoma, was not given before going for the excision of this tumor, Joanna.
The single shot
of any benefit?
The single shot radiation was given at Mahamana cancer. It was shown in the slide also. So 6-day single shot radiation, but it was not effective as the tumor, when the radiotherapy was given, the tumor was almost 16 into 20 centimeter in size. So single shot radiation was given, but then he was referred to us.
Was a Ewing's tumor a differential diagnosis? Because, if the Ewing's tumor is there, it melts like anything with the radiotherapy.
Yes, sir. So, but this was a proven case of chondrosarcoma.
Okay, thank you.
Thank you, sir.
Thank you, sir. I request Dr. Abhishek Pathak. You can unmute and ask your question.
Thank you, Dr. Abhishek. First of all, a very good and a nice presentation of a case. 2 comments and a question which has already been asked by Dr. Abhishek. So my comments are ideally the name and the video of the patient should not be shown. So I should be masked and name should not have been disclosed. And just a small comment, when you talk of proton beam therapy being the gold standard of treatment, you should remember the literature, whatever you've shown, are all the case series. You do not have not even a comparative arm to it. So giving the statement that it is the gold standard of treatment is still doubtful. This is your speculation because it comes out of the case series and 10 years follow-up and of mortality data is there. So probably that is the reason you told, but I think you need a comparative arm to bring out the gold standard of any treatment, right? Thank you. And the other part has been already asked by Dr. Abhishek Pandey. Thank you.
Thank you,
Thank you. Thank you, Dr. Pathak. I request Dr. Sandeep Loha, you can unmute and ask your question. Okay, I think there is some issue. The question Dr. Sandeep has posted in the chat, what is the prevalence of this tumor in India?
I have already shown in the slide point.
Okay, so can you answer it again?
0.1 to 0.2% of the intracranial cases.
Indian data is actually not available. This is the global data.
Okay. Dr. Rajiv has already shown in the slide the Indian data.
No, sir, it is global data, sir.
Yes. So he was asking about the Indian data. That's why I again asked.
Okay.
Okay. Thank you, Professor Ravi Shankar. And I now move to the second presentation. It's from Regional Institute of Ophthalmology, and the moderators are Dr. Prashant, and the moderators are Dr. Prashant and Dr. Deepak Mishra. I request the moderator to initiate the second presentation.
Good morning, everybody. Namaskar. We have come with a case which concerns everybody because diabetes concerns everybody. Dr. Archana, our JR3, is going to present this case and then we will discuss.
A very good morning to everyone. I'm Dr. Archana, Junior Resident in Regional Institute of Ophthalmology. And today we'll be discussing the journey of a young diabetic who developed diabetic retinopathy. So starting with the history, a 45-year-old female housewife resident of Pandepur, Varanasi, presented to us with the chief complaint of diminution of vision in both of her eyes for 2.5 years. Coming to the history of present illness, the patient was apparently asymptomatic 2.5 years back when she developed diminution of vision in both of her eyes, which was gradual in onset, progressive in nature, and it was painless. The diminution of vision was mild to moderate grade in severity, such that she could not see television images and newspaper headlines as clearly as she did before. But she could do most of her daily routine work independently. So she ignored this problem for some time and then she visited a private practitioner where she was told that she had developed some diabetes-related retinal problem, and there she was advised intravitreal injection and laser. The patient was given one intravitreal anti-VEGF injection in her left eye and pan-retinal photocoagulation was done in her right eye. According to the patient, there was slight improvement in her visual status initially, which again deteriorated after few months. And due to COVID-19 restrictions, she could not complete her follow-up. After around 1 year, she developed sudden, painless diminution of vision in her right eye, for which she visited to ROPD, and here she was diagnosed with right eye vitreous hemorrhage. And for that, she was kept under observation with few topical anti-inflammatory medications along with intraocular pressure monitoring. And so, according to the patient, there was mild improvement in the visual status of her right eye on her further visits, but there was again loss to follow-up. And around 2 months back, this patient again visited our OPD with a complaint of diminution of vision in her left eye. Coming to the negative history, the diminution of vision was not associated with any pain, redness, flashes of light, black spots in front of the eyes, or distortion of images. Coming to the past history of the patient is a known case of type 2 diabetes mellitus for the last 18 years. And as per her documents, she has had couple of visits to our hospital 6 years back for fundus evaluation, although at that time she did not have any vision related complaints. And at that time, she was diagnosed with a non-proliferative diabetic retinopathy changes in both of her eyes, and she was advised for more frequent follow-ups. This is a fundus diagram which we draw in our OPDs while doing indirect ophthalmoscopy. This was provided by the patient.
Dr. Archana, sorry to interrupt here. The total duration of diabetes was 15 years, right?
Sir, 18 years.
18 years. And what treatment patient was taking, and how was the HbA1c control?
Sir, sir, we'll come to the treatment history, but the patient was taking oral hypoglycemic agents initially.
Okay.
Yes. Sir, at 6 years back, she had some diabetic retinopathy changes and was suggestive of mild non-proliferative diabetic retinopathy. And there was no history of hypertension, trauma, or any previous ocular surgery. Coming to the personal history, the patient is of average build, vegetarian diet, and there is no history of smoking or alcohol. Sir, in family history, there is history of similar complaints in her father and one of her brother also. Coming to the treatment history, after being diagnosed with type 2 diabetes mellitus 18 years back, the patient was...
Archana, in the family history, you told that there is similar illness. Which similar illness you are mentioning? It is the visual part or the diabetes part?
Sir, diabetes part. The patient, the father was having diabetes and her brother was also having diabetes.
Clearly mentioned. Otherwise, it will be very ambiguous to say.
Yes, sir. Okay, sir.
Okay.
So, in the treatment history, the patient, after being diagnosed with type 2 diabetes mellitus, the patient was initially started on oral hypoglycemic agents, and she was taking tablet metformin, 500 milligrams BD, but her blood sugar level was not controlled, so the dose of metformin was increased up to 1500 milligrams per day. And when the blood sugar was not even controlled on this dose, the other oral hypoglycemic agents were added like glimepiride and voglibose. And when the sugar level was not even controlled on these three oral hypoglycemic agents, the patient was started on insulin. And for the last 3 years, the patient is taking subcutaneous insulin glargine, 12 units at bedtime. Coming to the examination part, in general examination, the patient is well oriented to time, place, and person with average build. And the vitals were, pulse rate was 78 beats per minute, regular in rhythm, normovolemic, with no radioradial or radiofemoral delay. So blood pressure was 132 by 76 millimeters of mercury in right arm sitting position. Her respiratory rate was 15 per minute, and temperature was afebrile. And there was no pallor, icterus, cyanosis, clubbing, or pedal edema. Coming to the systemic examination, in central nervous system, all the high mental functions were normal. Cranial nerve examinations were also normal. And in cardiovascular system, normal S1, S2 was heard, and there was no murmur. And in respiratory system, breath sounds were normal. There was no added sound. Abdomen was soft, non-tender, and there was no organomegaly. So, coming to skin examination, the insulin injection site was examined, and there was no pigmentation or lipodystrophy. And in foot examination, the skin appeared normal and there was no ulcer, and the pedal pulses were also normal. So my findings are confined to the ocular examination. Coming to external ocular examination, bilateral facial symmetry was present with normal head posture, and both the eyebrows were at same level with normal eyelashes. There was orthophoria in primary gaze, and all the extraocular movements were full and free. Coming to the torchlight examination, in both eyes, the conjunctiva was normal in sheen with normal conjunctival vessels. Cornea was normal in shape, size, and transparency. Also, the corneal sensation was normal. Anterior chamber appeared normal in depth on torchlight examination, and the pupils were normal in shape, size, and position. And both the direct and consensual light reflexes were normal. Coming to the visual status of the patient, the uncorrected visual acuity of the right eye was 6/36, and there was no further improvement with pinhole. And the uncorrected visual acuity of left eye was 6/60, and which further deteriorated to 4/60 with pinhole. And on subjective refraction, for a distance, there was no acceptance, and the near vision was n/12 with plus 1.5 diopter sphere. Color vision was also normal.
Dr. Archana, when you are mentioning the visual acuity, just go to that slide. Yes. What does it mean that there is no further improvement?
Sir, usually if the patient is having any refractive error, the visual acuity will improve with the pinhole.
Okay.
Uh,
So what does it denote?
Yes, pardon, sir?
What does it denote?
Sir, in this patient, this denotes that in left eye, if there is further deterioration with pinhole, that means we have some macular pathology. That is why the vision is deteriorating with pinhole.
So in the right eye, there is no further improvement with the use of pinhole. So that means there is more deterioration in the right eye?
No, sir, there is no deterioration. The vision was similar with pinhole also. That
Okay.
means there was no improvement with any refraction or spectacles.
Okay. Okay.
So coming to the slit lamp examination, all the findings of torchlight examination were confirmed on slit lamp examination with normal conjunctiva and cornea, and the anterior chamber depth was assessed with the help of Van Herk grading, and it was found to be normal. And the iris was normal in architecture and color, and in lens, there was grade 2 nuclear cataract. Coming to the intraocular pressure measurement, it was done with Goldman apprenation tonometer at 2 p.m. And the intraocular pressure in right eye was 16 millimeters of mercury, and in left eye it was 14 millimeters of mercury, which was normal in both eyes. The normal range of intraocular pressure is 10 to 21 millimeters of mercury. Coming to the gonioscopy, in this we see the angle structures. It was done with Goldman 2-mirror gonioscope, and in both eyes the angles were found to be open. Shermer test was also done to rule out the dry eye disease in the patient, as the diabetes can cause dryness of the eyes. And the readings were 16 millimeter in right eye and 19 millimeter in left eye, which was normal. So coming to the fundus examination, the fundus was examined. The pupil was were dilated with 0.8% tropicamide and 5% phenylephrine. So this is a fundus photo of right eye taken by a fundus camera, and in right eye the media were hazy, and the optic disc was normal in size, circular in shape, with well-defined margins. So as we can see, and the arteriovenous cup disc ratio is around 0.3. Also, there are some neovascularization of the disc present, which can be better appreciated on this red-free photograph of the fundus. Here, this is the neovascularization of the disc present. And so, the vessels are arising from the center of the disc and dichotomously branching with the arteriovenous ratio of 2:3. And there are multiple hard exudates, these yellowish lesions with well-defined margins suggestive of hard exudates are present over and around the macula with absence of foveal reflex. Also, there are multiple dot and blot hemorrhages and superficial hemorrhages are present all over the posterior pole. Also, we can appreciate that there are these all multiple laser spots are present, as pan-retinal photocoagulation has already been done in the right eye of the patient. Coming to the left eye fundus examination, the optic disc is the media were clear. The optic disc is normal in size, circular in shape, with well-defined margins, with a cup disc ratio of around 0.4. The vessels are arising from the center of the disc and dichotomously branching with the arteriovenous ratio of 2:3. And there are multiple hard exudates present over the macula and around the macula with absence of foveal reflex. Also, multiple dot and blot hemorrhages and superficial hemorrhages are present. And there is a girdle of these yellow lesions with crenated margins is present temporal to the macula, encircling an area of around 2 to 3 disc diameter, suggestive of circinate retinopathy. So based on the history and examination, our provisional diagnosis is right eye proliferative diabetic retinopathy with high-risk characteristics with grade 2 nuclear cataract, and left eye severe non-proliferative diabetic retinopathy with clinically significant macular edema with grade 2 nuclear cataract. So for confirmation of diagnosis, some investigations were done. In systemic investigations, although the blood sugar level at this time was normal, but her HbA1c level was 8.4%. Blood pressure was 132 by 76 millimeters of mercury. Lipid profile was borderline, and complete blood count, liver function test, renal function test, and thyroid function test were within normal limits. Coming to the ocular investigations, color fundus photography was done for the documentation of the retinopathy and to see the response to the treatment. And then optical coherence tomography was done. Optical coherence tomography is a non-contact, non-invasive imaging modality, and it produces cross-sectional images of the macula, allowing objective evaluation of the macular thickness and evaluation of vitreomacular interface. So this is the OCT image of right eye. In OCT image, we see mainly four things. This is vitreous phase, and this is vitreoretinal or vitreomacular. This is the macular area. This is the vitreomacular interface. These are all intraretinal layers, and this is retinochoroid junction. So in this, we can see that the vitreous phase, there are multiple hyperreflective foci present, and also along the vitreoretinal interface. The central macular thickness is 192 microns, which is in normal range, and there are multiple hyperreflective areas present within the intraretinal layer, suggestive of hard exudates, and there is disorganization of outer retinal layers with a normal choroid phase. So this is the OCT image of left eye, showing normal vitreous phase with altered vitreoretinal interface. There are multiple hyperreflective foci present along the vitreoretinal interface, and the central macular thickness is 368 microns, which is increased, and the overall retinal thickness is 567 microns. And there are also multiple round hyporeflective areas are present within the intraretinal layers, suggestive of cystic fluid-filled spaces, suggestive of cystoid type of macular edema, and the outer retinal layers are disorganized with a normal retinochoroid junction.
Dr. Archana, can you explain the different colors which is there? What's the importance of it?
So this is standard color coding in the optical coherence tomography.
Okay.
The hyper reflective areas, few layers in the retina are hyperreflective, and mostly the nuclear layers in the retina are hyperreflective, and the plexiform layers which are present in the retina are hyperreflective. And there are different pathologies in different layers of the retina which show different reflectivity on the OCT. So for example, these hyperreflective dots which are present, they are mostly suggestive of hard exudates.
Okay.
So after the confirmation of our diagnosis, we are coming to the treatment part. As this patient is having in left eye a center involving cystoid type of macular edema, so the best option available for this patient was intravitreal anti-VEGF injections. So we counseled the patient for intravitreal anti-VEGF injection. And this slide shows the steps in the administration of intravitreal anti-VEGF injection. The drug which we injected was ranibizumab, and the dose was 0.5 milligram in 0.05 ml. And after proper cleaning and draping of the patient, of the left eye of the patient, the site of the injection was identified with the help of a caliper. The injection is given through pars plana, and the distance of pars plana differs according to the phakic status of the patient. So our patient was a phakic patient. So the distance at which we gave the injection was 4 millimeters from the limbus, and the after cleaning and draping, the drug was loaded in the insulin syringe, sterile insulin syringe, and the injection was given. So after the injection, we are coming to the follow-up of this patient. The patient was first followed up at 24 hours. When she came after 24 hours, the history was taken, like if the patient is having any complaint of pain or any redness in the eye, visual status was assessed, the intraocular pressure was assessed, as anti-VEGF injection can cause rise in the intraocular pressure, and other injection related complications were also assessed. And the patient was also followed up after 1 week, and similar things were assessed. And then when the patient came after 6 weeks of the injection, the visual acuity, there was improvement in the visual acuity in the left eye of the patient from 6/60 to 6/24. And also there was improvement in the retinal thickness, which we can see here. And this is the OCT image of left eye of this patient before and after the injection of intravitreal anti-VEGF. We can see that the overall retinal thickness was improved from 567 microns to 330 microns. That means the retinal edema has resolved a little bit, although the foveal contour was still not achieved. So as we all know that diabetes mellitus is a global epidemic, and the World Health Organization estimates have revealed that the global prevalence of the diabetes among adults over 18 years of age has risen from 4.7% in 1980 to 8.5% in 2014. The 9th edition of Diabetes Atlas by International Diabetes Federation, released in 2000.
Archana, I am interrupting you here because I think the time for the presentation is over. So this we can discuss in the discussion part when we will take the question from the chat. I request the moderator, if they want to add something in the presentation, they can add. Then we will start taking questions in the chat.
We brought this case here because diabetes is a very common thing. But what is uncommon is that being carefree and being ignorant are two areas which are very close, and the lines are blurred. So this is a patient who contracted diabetes at the age of 27 years. And she kept on, be careful, and she was not careful. And she left also follow-up. And after about 12 years, she developed retinopathy. And it is also surprising that only retinopathy is present and all other complications like nephropathy and like other complications were not present. This is the primary pathology that came into it. And despite ignorance and not taking treatment and regular visits, now at the age of 45 years, she has lost a considerable amount of vision because of diabetic retinopathy, which could have been saved. So this was the basis of the importance of follow-ups in diabetes is very important, especially with eye diseases. If the diabetic retinopathy takes over, this was the basic reason we brought this case here. Okay,
thank you, sir. Sir, this patient was having diabetic for last 15 years.
18 years.
18 years. Yes. And she was diagnosed at the age of 25 years.
27 years.
27 years.
28, yes.
So, so total duration of diabetes is 18 years. So, yes. Diabetic retinopathy changes can be there. It's not nothing unusual.
Diabetic retinopathy changes can be there, but the amount of follow-ups then need to increase. That means for the past so many years, she must be having regular diabetic macular edema, and she must be having a compromised vision, which she ignored because her work was going on.
Yes. So that means the diabetes was very uncontrolled in this patient.
Yes.
For last 18 years, diabetes was uncontrolled. So when you, Dr. Archana, when you are presenting the case, yes, you mentioned about the treatment the patient was taking, and when the patient was started on insulin. And for the last 3 years, patient was on, I think, long-acting insulin. Patient is taking Largine. Right? And the last HbA1c report which you mentioned was, I think, it's almost 8.6 or 8.5, as I remember. So what do you think, like a patient with diabetes, particularly type 2 diabetes, when should the retinopathy changes should occur?
Sir, in type 2 diabetic retinopathy, it can occur at the time of diagnosis also when the patient is diagnosed. So we have to screen, initial screening should be at the time of diagnosis. And if there are no retinopathy changes, the further follow-up should be at 1 year. And when the diabetic retinopathy changes appear, the follow-up should be accordingly. For example, if there are mild diabetic retinopathy changes, the follow-up should be at 60.
So that's very important point. At the diagnosis for diabetes, when we are seeing the HbA1c value, cutoff value is 6.5. The cutoff value 6.5 is chosen because at that point the retinopathy changes starts.
Yes.
So we have to start early diagnosing it. Okay, when you are mentioning the diabetic retinopathy changes, the severity, their severity gradings are there for
Yes,
retinopathy changes.
Yes, sir. ETDRS grading is there.
Okay, so you mentioned in your presentation
Yes.
the severity grading.
Yes, sir. Initially, when the patient came here for initial screening 6 years back, she had started mild non-proliferative diabetic retinopathy changes, but there was no vision related complaint. So she was advised to for more frequent follow-ups. Which, if she would have done regular follow-ups, the diabetic retinopathy changes would have been detected earlier, and the management would have been better.
And where the patient was follow up for diabetes, where in our institution or outside?
Sir, outside. The diabetes follow-up was from outside.
From the outside, because I was wondering, the patient was taking oral hypoglycemic agent for such a long duration, and the HbA1c was not controlled, and patient was initiated insulin at that very late stage. So when you have chosen the VEGF, so how do you decide that there are various options available? So how do you decide which VEGF to be chosen for this patient?
Sir, there are other options also. For example, bevacizumab and aflibercept also. As bevacizumab is a off-label drug and it is not FDA approved. And the next option is ranibizumab. So we decided for ranibizumab in this patient.
Why?
Actually, it is not. You must have heard, Dr. Abhishek, that there are so many instances of injections being given in the eye and the patient suffering loss of vision at various places. Usually it comes in the newspapers and the news. So this is because basically bevacizumab was a drug which is used for colorectal carcinoma. So this was off the label use for diabetic retinopathy. It works almost the same, but it is not allowed because it was not FDA approved, and now the CGI also has not approved it. Ranibizumab is the drug which is approved for eye. So we use ranibizumab. Aflibercept is a much better drug, anti-VEGF, but it is costly and many times it is not available. So ranibizumab is the one we choose.
There are various toxicities associated with this drug. So how you follow up?
Yes, sir. As I have mentioned also in the slides, that there can be raise in the intraocular pressure. There can be endophthalmitis also. So first for few days we have to monitor the patient closely for especially for intraocular pressure and for infection related complaints.
Okay. Any cardiac toxicities also? Okay. I request Dr. Abhishek Pathak. Dr. Pathak, you can unmute and give your feedback.
Thank you, Dr. Abhishek. Again, my part has already been asked by you. My question was bevacizumab, which is relatively cheap. Why did they use? And obviously the points are well taken. And I asked about the insulin therapy and the timeline associated with it, because the DCCT trial and clearly that they had that data where they had the intensive insulin arm had early deterioration of the vision loss. And I would also like to ask comments from sir regarding the pan-retinal photocoagulation, whether it is available and you people do it. Any comments on that?
Actually, pan-retinal photocoagulation is a very good treatment, but it is just like an amputation. You are converting hypoxic areas into anoxic areas. So basically you are burning areas so that less of retina requires food and the hypoxia becomes less. I mean, the oxygen and the glucose and other things become ample for the rest of the retina because a portion of the retina is being burnt. So this is not the best treatment. The best treatment is to use this vascular endothelial growth factor inhibitors, VEGF inhibitors. They will reduce the edema. They are anti-inflammatory. They reduce the new vessels. So this is basically a superior treatment as compared to PRP, pan-retinal photocoagulation. Pan-retinal photocoagulation actually supplements the therapy with anti-VEGF. It is a cocktail. We can use both depending upon the patient's severity.
So sir, are there any randomized trials comparing pan-retinal with
Yes,
VEGF versus not?
There are randomized trials comparing pan-retinal photocoagulation with anti-VEGF. There are trials comparing both together with anti-VEGF and both together with PRP.
Thank you so much.
Thank you, sir. I request Professor S.K. Singh, sir. Sir, your comment on the presentation.
Thank you, Abhishek. First of all, I congratulate the ophthalmology team for presenting this case. Few questions I saw in the chat box. The question number 1, was it type 2 diabetes or any other diabetes? Though it was young onset, age of 27, 28, young onset diabetes could be type 2 also. But usually we call maturity onset diabetes of young. MODY should also be a second differential. Type 1 diabetes should not be because patient had been on oral drugs for many, many years and had not developed diabetic ketoacidosis that goes against diagnosis of type 1. Maturity onset diabetes of young has autosomal dominant family history, but they usually do not develop severe diabetic microvascular complications as this patient had. Almost after 6-8 years of detection of diabetes, he had a diabetic retinopathy. In type 1, usually diabetic retinopathy develops by 5 years of duration. In type 2 diabetes, it can be at time of presentation. Almost 24-25% cases can have diabetic retinopathy at onset at the time of detection of type 2 diabetes. This is because they had unknown duration of type 2 diabetes ongoing, and they are detected only when they have some problem or by screening. So there may be diabetic retinopathy at the onset of type 2 diabetes, and this is because time is spent undetected for type 2 diabetes. Retinopathy, we should have a retinopathy clinic. That is most important message. The follow-up would be easier if we have diabetic retinopathy clinic and patients are referred to the clinic for regular checkup. At the onset, diabetic retinopathy evaluation should be done, and then every 3 yearly, those who have a strong family history of retinopathy should also be checked every yearly. So that should be the usual pattern. In type 1 also, the similar follow-up should be done after 5 years of detection of type 1 diabetes. So in this case, a regular follow-up was not done. Regarding the diabetes control, oral and insulin both can be of help. No matter whether we use insulin to control or we use OHA and insulin combined to control, the goal is to control the A1C to less than 7%, and that was not achievable, unfortunately, in this case. That should have been the target. The question that initial insulin therapy can deteriorate, yes, there may be slight deterioration. There may be some appearance of microaneurysm following first year of intensive insulin therapy, which was not done in this case. Intensive insulin therapy, there may be some early deterioration, but subsequently that improves, and Steno trial has shown the early deterioration, not in DCCT. In DCCT, it was type 1 diabetes intensively controlled, and they demonstrated there was a reduction in diabetic retinopathy almost 35-38%. In UKPDS, which was done in type 2, there was a reduction in diabetic retinopathy with intensive glycemic control, irrespective whether it was oral or sulfonylurea or the insulin therapy. No good drug is available, good control of sugar, and fibrate have been shown to improve little bit of diabetic retinopathy, but that is not a universal recommendation to use fibrate to prevent diabetic retinopathy worsening. So now in this case, laser photocoagulation is helpful. Anti-VEGF, I do not know if that changes the natural history, that improves the vision. There will be improvement in edema and there will be improvement in vision for some time, but in long term, whether it changes the course of progression of diabetic retinopathy, that has not been established, and therefore we always question whether anti-VEGF therapy is of great help in preventing further deterioration of diabetic retinopathy. But as of now, temporarily benefit is there. Macular edema is very well improved by anti-VEGF, but neovascularization may not be prevented. It may be improved a little bit at time it is injected, but overall further deterioration in diabetic retinopathy is not achievable by anti-VEGF. Pan-retinal photocoagulation definitely is the treatment available to prevent further deterioration of progression of proliferative diabetic retinopathy. Focal photocoagulation has no role. I don't think there is a role except that sealing the bleeding vessels and preventing vitreous hemorrhage. So this is, I think, we still need to develop a very good dedicated diabetic retinopathy clinic. And I'm sure RIU will develop it because most of our patients are neglected. I must accept this unless we have a dedicated diabetic retinopathy clinic, dedicated maybe once a week. I think this is what I desire that we should have in RIU. Thank you.
Thank you, sir. I request Honorable Director, sir, your comment on the presentation.
Thank you, Dr. Abhishek. Already we are quite late now. In the beginning, first case, I could not join due to the issues in technology. That sometimes, though it helps, sometimes creates problems also. I tried a lot, but in the end, some jugaad was used to join this meeting. Very good surgery that they have done. Excellent work by the neurosurgery team along with the plastic surgery team. But as I heard that patient was registered is Mahamana Cancer Hospital, so previous radiotherapy, whether you say neoadjuvant radiotherapy was given in Mahamana, then I'm curious to know how patient landed here in neurosurgery from Mahamana. They have good head and neck surgical oncology unit. Even after treating here, patient was referred back there. Why not radiotherapy here? That is just, but in the discussion part, though treatment was not given here, we could have included for their comments radiotherapy, radiation oncology, and surgical oncology units for the academic purpose. That could have been better. But patient management wise, excellent surgery. They have done good job. Congratulations to the team. Though the outcome later on follow up, that is questionable how the patient will behave. And second case, very good presentation by the resident and good discussion thereof. Even Professor S.K. Singh's comments, all this very good, learned a lot. And I am hopeful that with the RIO, now they have state-of-the-art facilities, but all these clinics, whether diabetic retinopathy clinics, vitreous clinics, different types, many clinics are possible in ophthalmology. They will definitely look into it and start as early as possible, maybe on the weekly basis or whatever, according to the availability of staff and other facilities. They have to look into it, but we should move towards that, to having good clinics so that patients are benefited, as it is a on papers, of course, it is a tertiary care institute, but we primary care also treat. That has become every tertiary care institute. But I'm hopeful these clinics will start. But otherwise, very good presentation and good discussion. Congratulations to both the presentation, both the teams. Good work done. Thank you very much.
Thank you so much, sir. Thank you so much.
Thank you, sir. So thank you everyone for joining this clinical society meeting. See you at the next meeting. I close the meeting now.
Sir, good morning.